Di level 2 ni adalah tandas, iaitu di bahagian kanan dan kiri, dan juga surau di level 1, dan smoking area pula di lobi tingkat bawah. Jika berlaku kecederaan kecil, tuan-tuan boleh dapatkan first aid box yang terdapat di counter reception di bawah. Okey, semoga tuan-tuan dan puan-puan berada dalam keadaan selamat dan sihat sepanjang majlis ini berlangsung. Sekian, terima kasih.
Thank you, Safety Officer. So it has come to my understanding that there were some problems with the registration outside the hall. I would just like to remind all participants that you can still register your name if you can just scan the QR code on your lanyard. It's just behind on the back cover of your lanyard. So without further ado, I'd like to invite our first speaker for today's event. He is the chairman of the IECG, so please welcome the Honorable Dr. Muhammad Ghazali bin Abdul Rashid. Please welcome.
Assalamualaikum warahmatullahi wabarakatuh. Okay, now we are almost 8 a.m. sharp. I hope you all okay, calm down, all still tachycardia because rushing. Okay, but don't worry, we will start this with the easy topic first. We go first with our first is IECG workshop topic, which is normal volume ECG. Okay, our ECG, the normal ECG, of course, is sinus rhythm. Okay, this is the normal roof that we all have. We will go through all this, every and each part of the normal roof, and we will discuss about the normal variant of that. Some are quite commonly encountered, but some are rarely encountered. Okay, we start with P-wave. Okay, normally P-wave occur in all leads, whereby the lead 2 record the most upright diffraction. If P-wave, if you see P-wave inverted in lead 2, it is unlikely the rhythm is sinus. Alright, P-wave normally inverted in AVR, but it can also be inverted in AVL if case complex are predominantly negative in the leads. Okay, in V1, the normal P-wave can be 3 forms, upright, biphasic, or inverted. Okay. In the case of dextrocardia is the mild position of the heart. Okay, the heart still normal, but it is mildly position. Mild position. So you should suspect that when you see in lead 1 the P-wave inverted, and in that list the gas complex negative and T-wave inverted. Okay, and you also can see absence of normal RV progression from V1 in the prokaryote units from V1 to V6. Okay, the other features, patient can have right axis deviation, and instead of have negative deflection of P and T in AVR, patient will have positive deflection. Okay, this is the example of IECG in let's look at the okay. Okay, this wave inverted in V1, alright. In AVR, it is positive deflection. Okay. You can also see the right axis deviation. All right. Okay. Next is chaos complex. We start with Q wave. Of course, Q is the first wave of chaos complex. Namely, it is negative deflection. And we all know it represents activation of vertical septum from left side to the right side, except in lead 3. I'll explain to you later. Normally, the normal Q wave recorded in the left side of the precordial leads, and also in lead 1 and AVL. So if you noted Q wave in right side of precordial leads, it is pathological. Okay, the size of Q wave depends on the thickness of the ventricular septum. If it is thicker, then it is wider and deeper. But normally it is less than 1 mm width and less than 3 mm depth. Okay, in lead 3. In lead 3, if you see Q wave in lead 3, actually it doesn't represent septal Q wave. That's why it can be more than 3 mm in depth, but less than 5 mm in depth, and the height is less than 25% height of R wave. And this is the normal Q wave in lead 3 will disappear on lead inspiration. Okay, next we go to the R wave, the positive deflection after Q wave. Okay, the R wave may exceed 25 mm height in the lateral chest lead in the fit, teen, and young peoples. Okay, when you encounter RBB, there are pathological RBB and normal variant RBB. Normally for normal variants, it is partial RBB, or some people call incomplete RBB. The pattern is still RSR pattern in V1, but chaos complex is less than 120 milliseconds or less than 3 small dots. Okay, this normal variant commonly seen in children. Okay, this is the RSR pattern in V1. Okay, the expected changes after RSR is inversion of the T. Alright, but you can clearly see it is the complex is narrow. The chaos complex is less than 120 milliseconds or less than 3 small dots. Next, we go to the ST segment. Okay, ST segment, it actually represents the phase 2 action potential. How to remember? Okay, the flat line, phase 2 action potential. Okay, ST segment also flat. Okay, so it should be at the baseline of TP. Okay, remember, isoelectric line, we refer to TP, we don't refer to PR interval. Please remember that, because some of the junior MO still look at the, still refer PR interval as the isoelectric line. Because, why? Because in some condition, PR interval can be depressed, like in pericarditis. So, we don't use PR interval as our isolated line. We refer the isolated line to TP interval. Okay, ST segment can be elevated, can be normally elevated in the case of you normally encounter high takeoff. So what is the definition of high takeoff? High takeoff is a sea elevation at the transition zone. So where is the transition zone? In the precordial leads, when you see the height of R wave and the depth of S wave equal, that is the transition zone. So one leads before that and one leads after that, the three leads we call that transition zone. That is normally we see high takeoff, the SC elevation in the transition zone. Okay, you may also see SC elevation in early repolarization. Okay, the features of early repolarization I will show to you later. There are several criteria to say it is benign early repolarization. Why? It is important to differentiate between pathological SC elevation with the normal variant of SC elevation. And we shouldn't miss the pathological ST elevation. The non-specific ST depression normally seen in mid-3. When you see ST depression in mid-3, but when you look at the related leads, like AVF, it is absent. So it is also normal variant. Okay, ST depression can be present in pregnant lady. It is also normal for them. Okay, but of course, even though it is normal variant, we have to correlate clinically. Normal if patient is symptomatic. Okay, next we go to T-wave. Okay, T-wave represent repolarization of the ventricles. Okay, the phase 3 action potential. Okay, remember T-wave actually is the most variable part of ECG. There are so many forms of T-wave, but they can still normal. Okay, and the variation can occur from day to day. We always encounter T inversion in AVR and V1. The T-wave can be inverted in mid-3, I mentioned before, but not in AVF. And if you see the T-wave, the isolated T-wave in mid-3, it can be reversed with inspiration. Okay, T-wave also inverted in AVL, particularly if P-wave also inverted in VL, I mentioned earlier. Okay, and you can also see T inversion, generalized T inversion in the case of hyperventilation syndrome. All right, and another thing is T-wave. T-wave normally inverted in V1, V2, but in blacks people, they can have up to V3 T inversion. It is still normal for them. Okay, next we move to U-wave. Okay, U-wave, okay, is the last component. Okay, the last component of ventricular repolarization. It represents repolarization of his Purkinje system. Now, the U-wave normally seen in anterior chest lead. Okay, anterior chest lead V1, V2, V3. Okay, it normally have negative diffraction in AVR. It is only significant or pathological when it follows flat or inverted T-wave, like in case of hypokalemia or hypercalcemia. Okay, we will discuss further when during the lecture of non-cardiac ECG. Okay, about the axis. Okay, in tall people, they may have minor right axis deviation, normal for them. Okay, in fact, people in pregnancy, they can have minor left axis deviation because of the heart push upwards become more horizontal. Okay, the abdominal fat also push the heart a little bit superior. Okay, in pregnancy. Okay, in pregnancy, in week 3, the depth of S wave is more than the height of R wave. Okay, it becomes equal in week 2. Maksudnya is less elevation lah. Okay, normal for pregnant lady to have sinus tachycardia and to have supraventricular or ventricular extrasystoles. Okay, normally no clinical important except when they become more frequent and multiform. Okay, supraventricular extrasystole or ventricular extrasystole, they can be unifocal or multifocal. Okay, in pediatrics. Okay, in pediatrics, apart from they have no tachycardia compared to adults, normally the pattern of ECG that they have is the pattern of RVH, right ventricular hypertrophy. So in the children less than 8 years old, when you see the normal adult pattern, normally they already have LVH because normal for them is RVH pattern. But if you can see adult pattern, normally they already have LVH. So you also have to investigate. Okay. Okay, by 2 years, all other changes should have disappeared except T inversion in V1, V2. Okay, and by 10 years, the adult pattern should have fully developed, and it's quite common for them to have sinus arrhythmia. Okay, sinus tachycardia is very commonly encountered. It can be normal, it can be pathological. Okay, during exercise we have tachycardia, during pain, when temperature elevated, when we have mental stress, pathological cases like dehydration, sepsis, heart failure. Okay, we have sinus tachycardia. Okay, what about sinus arrhythmia? Okay, sinus arrhythmia is normal physiological phenomena most commonly seen in young and healthy people. Okay, whereby the heart rate varies due to reflex change in vagal tone during the respiratory cycle. During inspiration, the heart rate increases because of decreased vagal tone, and during expiration, the vagal tone restores, leading to decrease in heart rate. Right? The incidence, of course, decreases with age. What is the criteria for sinus arrhythmia? If you Google, this is what they will tell you. Okay, there will be variation in the PP interval. The shortest, the longest PP interval minus the shortest PP interval, it should be more than 3 small boxes. Okay. And PP interval I mentioned earlier, it changes with the phases of respiratory cycle. It lengthens and shortens. Okay, the P wave normally have constant morphology because it comes from the FMO. So it is sinus P, and PR interval must be constant. Okay, this is the example of ECG. Okay, you can see here variation. PP, okay, so I put here RR, same lah, okay. You can see eyeballing, easily to see RR rather than PP. Right, you can see the variation, but P is still sinus P, sinus P, and the PR interval is constant throughout the cycle of ECG and also cycle of breathing. Okay, sinus bradycardia also a common condition, commonly encountered. Okay, it is normal variant during rest, during sleep, and in some people. but of course you have to correlate clinically. Okay, in athletes, normally you can see very common in athletes. Majority are benign and related to physiological adaptation to the extreme levels of exertion. Okay, then we go to early reposition. I mentioned earlier, is normal volume, but because in BER there is ST elevation, so you have to be very you have to scrutinize ECG carefully before you diagnose BER. Of course, patient should be asymptomatic apart from having all these 7 criteria. Okay, the ST segment is diffuse. Normally, the left side of precordial leads, so lateral part of precordial leads, V3 to V6. It can be appear in lead 2-3 AVF. The ST segment concave outward. Okay, of course, it shouldn't be accompanied by reciprocal ST depression. And normally you will see the fish hook pattern, which is the predominant notch at the terminal portion of KS complex in the lead that has ST elevation. Okay, T waves in V6, usually much taller than ST segment. Okay, they're different from pericarditis. Pericarditis is the other way around. If we measure the ratio of ST segment, the height of segment to height of T wave, it should be less than 0.25 or 25%. Okay, normally the ST elevation in BER is followed by symmetrical large amplitude of T wave. And during tachycardia is less pronounced and more accentuated during bradycardia. So this is the example of ECG. Okay, in this ECG you can see the notch that I mentioned. Okay, the danger point. The ST elevation is concave. Okay, concave. And if you measure in V6, the height of ST elevation to the height of T wave, it should be less than 0.25. Okay, BER commonly seen in young, healthy patients less than 50 years of age. More than that, it is less likely. Okay, it is also seen in highly trained athletes, 25 to 40%. And I mentioned earlier, it mimics pericarditis or AQMI. You have to correlate clinically. Okay, PVC. There are many terms for PVC. Some people call ventricular ectopics, some people call ventricular extrasystole, ventricular premature beats, ventricular premature deposition, or are referred to the same thing. Okay, premature ventricular complex. Okay, if we have only single or not frequent PVC, it is normal. Okay, it doesn't require investigation or treatment, like this ECG. Okay, the PVC complex. Of course, ventricular complex is right. Okay, this is the criteria. PVC ventricular complex occur earlier than we expect KS complex in the next sinus impulse. In this, we expect the sinus. The sinus impulse, the next impulse is around here, but it comes earlier. Okay. Okay. The ST and T become discordant to the KS complex. Normally, it is followed by full compensatory pulse. What does it mean by full compensatory pulse? You measure the time from this complex to this complex, it will be equal to, you measure the time from this complex to this complex. It is different from PAC. PSC, there will be absence of compensatory pause. PSC is premature atrial complex, supraventricular. This is ventricular complex. Okay. The retrograde capture of atria may or may not occur. Okay, when it occurs, you can see the inverted P wave after the KS complex. We call that retrograde P wave. Okay, because the electrical current from ventricle sometimes go up to the atrium, pass through the tract and goes above and appear as retrograde P in the ECG. Okay, that's all for normal variant. Okay, if you have a question, I think you better leave it to the IECG exercise lah, because we are very packed of time, and then during exercise you can ask the questions that you have in all the lectures. Okay, but if you have time, then probably some of the speaker open to the question. There is no problem. Okay, that's all from me. Thank you very much. Wassalamualaikum warahmatullahi wabarakatuh. So enjoy the ECG workshop. Thank you.
Thank you, Dr. Hazana, for that very crucial and yet informative opening lecture for us today this morning. Now, of course, it is important for us to understand the normal variance of ECG because the eyes cannot see what the brain doesn't know. So now, without further ado, I'd like to invite our second speaker, the Honorable Dr. Azrin Othman, who will be speaking on STEMI equivalent. Please welcome.
Ini untuk kesadaran kita pointer itulah pointer ni lah bukan itu kan kita tukar batu pun nak bercakap itu kan
Okay. Assalamualaikum. Good morning. It's great to be here to be part of the team, the emergency room ECG course, basically. So we done in second goal. Okay, now I want to talk about anti-elevation microinfarction equivalence. So because time is really we need to rush times. Yes, it works. Okay. Now, when we start about STEMI, we want to know what we call STEMI from ECG-wise. So basically, everyone knows about it, that when you go STEMI, because of the coronary artery included, doesn't matter which part of the arteries, that manifested in ECG as the the ST elevation in two more contiguous leads, blah, 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 all this thing, posterior infarction, artery infarction, nuance element. These are typical ECG. Everyone knows about it. No big issues. But we want to start this one because we're going to talk about the STEMI equivalents. What are STEMI equivalents? You listen to what is STEMI first. Basically, okay. If people already know that, pardon me, but I have to do it for the sake of completeness. Okay, now we go to the next one. Now, this is the one that I'm going to highlight. I'm very lazy bums. I don't like to write. So I put in the descriptive or in picture types. So basically, arterial occlusions are the typical ECG, a repetition from the beginning. And then that's why the highlights, what I've been given task to highlight is basically the atypical ECG changes, the STEMI equivalents. Why STEMI equivalence is so significant, causing hemodynamic instability, morbidity, and mortality. Basically, it will lead to MI, death of heart failure, which is the common complications that we are fear most when we deal with acute coronary syndrome. So basically, what are the ECG changes that will most people from literature say the STEMI equivalence? Sorry, what happened this one? Oh, okay. So what did I do there? Got it then? No, sorry. All right. Sorry, Najib, how do you do this thing? Is it you have to read the computer? So, okay. All right. Injury time, you have to add up 2 minutes for me. Okay. Okay. Now, what we call about STEMI equivalence, most of literature will talk about these things. So, in Malay words, if you see the normal real life shows, calon-calonnya adalah basically calon-calon adalah the Welling syndrome, giving 30 waves, some whatever acceleration. Now, doesn't matter the names. Doesn't matter the names. What I'm going to highlight is what you remember. Doesn't matter. For Muslims, when we read Quran, you know what the rules, bila guna, but you do not know the rules, but you know bila nak dengar, bila jumpa tahu, kan? Okay, something like that. Doesn't matter. People will argue wetlands or whatever, winter, summer, autumn, blah blah blah. Doesn't matter. But you know the ECG, this is significant. Doesn't matter what's the name. It's bad. And of course, the extenuation. Okay, now we go to this one. Okay, now first, Welling syndromes. Again, repetition, doesn't matter the names, okay? But you know what ECG is. So, if you do not know anything, you just remember this thing. Look at this box and this box. That's about it. Doesn't matter the names. All right, if you know it better. Okay, you don't say, hoi, hoi, hu, sapa. So basically, Welling syndrome is clinical syndrome, biphasic or deeply inverted T-wave in week 2, week 3. What the hell is that? No one's know. Basically, what you do, biphasic, okay. Back 25 years ago when I started cardiology, how I remember this? Bentuk kotak, box sign, 90 degree there. So this called the interventional cardiology, we call interventional cardiologists, call this the widow signs. So isteri dia mati, dia tinggal suami yang ada. Okay, that's it, okay? It's biphasics. Okay, and then T-wave inversion. Do you remember these two? That's about it. Blah blah blah. Of course, probably people tell you this. This occurs usually during after in chest pain free stage. Blah blah blah. All these things. Yeah. So these are the things. Okay. Okay. Basically, I want you to remember this, and this is due to critical stenosis of the proximal left anterior descending artery. So of all the major arteries, LAD is the bad arteries, and the main engine, the support of the engine. Something bad, but you died, you got MI, you got heart failure, you got malignant ventricular arrhythmias, VTVF. So basically, this is the, okay, Welling syndrome. Okay. But lesson here, remember the ECG, if you got the Welling syndrome, if they do have symptoms, hold them. Do not go home. Tell the cardiologist, unless it's your typical AOR discharge. They have no choice. Okay. All right. We go to the next one. Okay, these are the ECGs, basically the box signs, blah. This is, okay, easy. Okay, the next one. Now, T-wave, this again, you see, this is more classical. Look at it. Look at it. Look at it. Look at it. Okay. Now, the next one, this is type B. Doesn't matter type A, B, C, D, E, F, G, H, Y, K, Y, Z. You know, this is bad signs. Bad signs, basically, T-wave inversion again, widespread. The deeper it is, the more significant it is. Okay? All right. The next one, again, the deeper it is, the more significant it is. Now, the game of this talk when we talk about Wellings is that you saw the biphasic T-wave inversion. If you can't remember anything, just remember them. Okay, fine. Okay. All right. Now, again, repetition. Why is Welling syndrome or this ECG are significant? They're significant because the critical stenosis of the left anterior descending artery, which is the most important left arteries in the coronaries. Okay, okay, and then they're because of occlusion of critical stenosis, the very high risk to develop MI or morbidity mortality. So, then, is there any other condition that could produce this similar ECG? The answer yes. What are they? Now, again, the calon-calonnya adalah this one, vasospasm, thromboembolism, RDB, blah, 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 blah. We're going to have that more in our tutorial. Okay. That is about develops again. Now I'm going to highlight a bit why am I telling lies. No technical differential diagnosis to be sure. So I show you now the evidence. For example, RBB. So when you got this, sorry, is it here? Is it? No, it's here. Or they highlight. Ajit, apa jadi? Okay. Now when you got RBB, you see the RBB because RBB different localization. So that's why the TV illusion like you did now. Okay. And then you got the RVH again. You see the ST elevation. The ST, that one, the ST elevation, deep, very deep. Okay. And then the LVH, because LVH more of the ST depression basically, that can come deep. Okay. And then of course the Bulgaria because the ST elevation, that one, that shows the ST elevation, the biphasic type, and hypokalemia because of the T wave inversion there. So these are examples. It can be differential diagnosis. Of course, to come with that diagnosis, you need integrated approach. You need the clinical features, you need other additional features. Okay, but of course, you need to exclude this acute condition because if you miss it, detrimental effects, both morbidity and mortality. So you have to. So it's no harm if you treat that first, if you're in doubt, basically. Okay, now this is raised ARCP saying, okay, now we go to the next one. We go to the next one. So this is summer, winter, whatever, doesn't matter the winter. Now, my personal experience, I only see these ones. Okay, I see one. Okay, this is called the winter signs. I cannot say the winter. You just say that when I saw the ECG, so I'll know what it is. Okay, basically, the winter is I don't know. It works now. The winter is upsloping. Here we go. Here we go. It's ST depression, and then followed by deep T waves. I always think these like hyperkalemic changes. I always think. So if I go hyperkalemic changes, look like, I always think these are differential diagnosis. Or if I go hyperacute MI, because it looks far away, MI, they can go to MI, even more likely go to MI. But before the see that? So first thing, we say that upsloping ST depression, and then tall symmetrical T waves. Okay. So what it do? Due to basically because it's the proximal lung anterior descending arteries, critical stenosis or occlusions, basically. And then lead to MIs. Okay? All right. Now this example. Now this one, sorry, this one not real life from textbook. Look at that. Again, ST depression, upright, T wave deep. Okay. On leads. So they call winter signs. Again, repetition there. This is again. Look at it. Precaudal leads. ST depression, upright T wave, right down. So look far away. You look that, it look like hyper K, isn't it? Now this one far away, if you didn't look at that, you will see how hyperacute changes. So that is the trick. Personally, if you see like this, the differential are these D winters, hyperkalemic or hyperacute MI. These three things. Yes. Right. Of course, it's easier to diagnose the winter because after retrospective. You know? Okay. All right, we go to the next one. Okay, why so this winter, summer, autumn, why very important? Okay, because it's usually acute occlusion of proximal to mid LADs, where it has developed MI. Basically same as the Wellen signs, basically the same. Okay, all right. Now, do you see this how often compared to the Wellens? Personally, and most people say this is a bit rare. I wouldn't say rare. Rare is not nice. Uncommon. Yeah, very nice. It's another way to say that you're not bodoh, but you touch a date. All right. Okay. Very nice. Okay. So this is winters. Okay. Differential could be, as I say, okay. Differential are the hyperacute T wave, hyperkalemic changes. Right. Of course, okay. Look at that. This is tall. Okay. This is hyperacute changes of MI. And then this hyperkalemia because of that. So look at that. You look at that. This probably not obvious, but look at that. That probably suspicious. Of the thing. And the lung depolarization. So these are the ECGs, are differential diagnosis of the winter. Now we go to the one that most people will be, I would say, you get used to it. Oh, there's elevation in AVR. Yeah, isn't it? Okay. Okay, this is more common. I wouldn't say more common. You are more at ease because you see more. And then, okay. Now The thing about the ST elevation in AVR, this is ST depression. Usually, most of you people say a left main stenosis. You're right, 50%, but bear in mind there are other differential diagnoses, or there are other categories. I will say other condition can present. CG, of course, the main is left coronary arteries, left main coronary artery stenosis, occlusions. Okay, basically it's an ST elevation AVR. So I make a box there, see the ST elevation, and ST depression with the blue things, widespread. Now, this is classical example. Isn't it? So this one you're all at ease. Even some of you, I wouldn't say, sorry to excuse, people thrombolize. And we'll talk about it later, okay? So again, this is kacang putih, easy. Alright. Okay, this again the repetition there, you see that direct arrow, ST elevation, AVR, and then widespread ST depression. Okay. So these again like violence or winters, we see this one, even they don't have symptoms, hold them, call the cardiology, ideally rush them to the lab. That's I will say ideally, okay, even practically maybe many obstacle words. Okay. Again, ST elevation, AVR, widespread ST depression, blue arrows. Okay, now why is significant with this one? Definitely because high risk of sudden cardiac death, hemorrhagic instability, failure, MI, more like the same. All right, the same. Okay, so differential diagnosis hypotension, hypoxia. I would gratitude to the emergency physician USM correct me, say a very nice way. He said what we say is subendocardial ischemia. He's definitely like because of hypotension, hypoxia, causing significant subendocardial ischemia. So it can present ECG like that, even though the coronary arteries are normal. Okay, and then tachycardia-related ST depression. All right, tachycardia-related ST depression cannot make it. We'll show you that. Okay. Now this is differential diagnosis. Okay, just now you saw obvious. AVR, ST elevation, widespread ST depression. Okay, now, what differential diagnosis? This is called tachycardia-related ST depression. Common. Look at that. The AVR elevated. Agree? Agree? Everyone see that? If blind panic say, if you can't see that, you are. Okay, never mind. Okay. And then the ST depression there, regulated. Even to diagnose ischemic in like this is class 3 by the guidelines, by the classification criteria. It's not, cannot. Okay. So, example, so differential diagnosis. Okay. Okay, now, sorry. Sorry, what I've done, sorry, Melia. So we go. Sorry. Here we go. Sorry. Okay, betul. Okay. I want to go to the next one, the significance of the. Okay, this is okay. Next one. Sorry, Dr. Ghazali. Okay, the next one, Dr. Ghazali. Terima kasih. Okay, thanks. Okay, now, if you cannot learn anything from today, or what I'm talking is just bullshit that you cannot make it, just bear with me. Just take this slide. Okay, the thing is that all these three things doesn't matter. You know the name, doesn't matter. You know, but in your mind, that you know the ECG changes. Yeah, high risk of STEMI, high risk of sudden cardiac death, high risk of hemorrhagic instability, high risk of heart failure. Ineffective medical conservative. It's not that really it's not working, it's working. But what you do is half-hearted. You have to go intervention. Alright? Doesn't matter stenting or bypass eventually. Or I would say revascularization, optimal revascularization. Okay. Okay. Again, the next step is that when you see again the STEMI equivalence, Wellen, the winter, blah blah, what's the name? Number one, hold them. Call cardiology. Look, admit them. If the cardiology typical lah. Aku tengah buat case lah. Buat apa? Hold them. Don't let me go away. Do whatever means. Optimize them, whatever. Alright? Hold them. If you go in peripheral hospital, even though asymptomatic, especially violence, you know, you're going to refer as soon as possible. They say, refer to clinic. Clinic? Berapa klinik? 3 bulan lagi. No. Come to casualties. Yeah? Okay. And then, especially the ST elevation AVR, people say, do you thrombolize? You will read in literature, it's been thrombolized and success. Unfortunately, we follow the guidelines. The guideline never mentioned thrombolysis in isolated AVR elevation. So what being done is off-label or whatever. So until today, these things, no evidence shows thrombolysis is the mainstay or treatment of part of the treatment Even though literature, you read some papers from China or whatever, they say success. But those doesn't reflect the current recommendation by guidelines by the statutory bodies, which are, Malaysia, we got CPG, America got American Heart Association, or American College of Cardiology, or European City Cardiology. Okay, so do not give normality. I think that's my last slide lah. Ada the time lah. Tak punya loceng pun?
You actually still have a lot more.
You own me lah. No, yeah, just about it. I think it's my super senior, Mr. Sri Buana. He's very glad to be here, Dr. Sri Buana. Should be cardiac surgeon, Okay. I think I am there. Okay.
Yeah, it's fine, Dr. Azri. But if you want to speak on the longer term, it's fine.
I've got nothing to say.
I see.
Oh, do you have to say?
So basically, because we have a lot of time left, so I'd like to open.
I thought it's from America. The end swing just now from America. Actually, from Newcastle.
So we invite the participants. If you have any particular questions to ask Dr. Azri, now would be a great time. Anyone to ask a question?
Good. They are boring. Sudah. Sorry, I'm just putting relax.
My doctor, I want to ask regarding the acceleration area and diffuse ST depression. Because some literature suggests that the acceleration area must be accompanied by acceleration V1.
Okay.
What's your say regarding that?
Okay. They are usually accompanied, but sometimes in isolation. The reason I didn't put that, because I thought nanti mesti dua-dua, it's either one. It's either one. Of course, the elevation V1 area is basically anatomically where the levels of the stenosis. If I mention that more, you'll be more confused. Proximal, the associated changes, So the aim is that, yes, we can have elevation in V1. Whether that one need thrombolysis or not, the answer no, because the guidelines say contiguously, dekat-dekat dia. V1 dekat dia tak ada, V2 tak ada kan? Saya tipu lah. Okay. No, just kidding. So still, even if elevation in V1 only single, isolated, so it doesn't fulfill the so-called criteria of thrombolysis, which is two contiguous leads. All over. So ada dua yang area satu. Ni dah. Tapi tak boleh lagi. Okay, is that answer your question, my dear? Thank you. Okay.
We still have ample time for Dr. Azri. The floor would like to ask more questions.
Can I take this time for my other lecture?
You try it to another.
Ganti dia lah, extra this one. I bring add to my other lecture. No, just kidding. Right?
I don't think we can do that. No, I was just so if there's any questions any more questions for Dr. Azri? The gentleman in the back. You can pass your microphone.
The mic for you. No, just kidding. The mic, this one.
Assalamualaikum Dr.
Waalaikumsalam.
I'm Mujahid, working in Sangatan Sabah. I just want to ask, because we see a lot of cases, AVR with ST depression in our hospital. So what we can offer for our patient, because we can do early with logistic referral, but we have very bad logistic issue with those transfer patients. So as a medical officer, what we can offer in our setting. Thank you, Dr.
Okay, let's back to how you treat ACS. Basically, it's non-ST ACS, not MR. What are you going to do? So first, of course, anything stabilized. Okay, you do all the echo, whatever blood. So in terms of treatment, what are you going to do? Okay, do antiplatelets. No antiplatelets, clopidogrel, or plus aspirin, cardioprin. No? If you want better still, in ACS, the using of ticagrelor are better than clopidogrel. Not procedural until you do intervention. So that's another thing done, okay? And number two, basically, this is ischemic beta blocker is a must, unless coagulation, and ACE inhibitor. So ACE inhibitor, if LV functions are good and not in failure, class 2. So, okay, class 2, okay? There's beta blocker and you go ACS is class 1. Okay, you have to do, okay? And then, of course, high intensity statins. You think this is definitely ischemic, you can use all anti-ischemics and isodine, whatever. Of course, the using of anticoagulant, you know, it range from fondaparinux or Clexanes or ivermectin, depends. And then, of course, the priority will be fondaparinux and then Clexane, you know. And of course, these are contraindicated, not available. For example, patient renal, significant renal dysfunction, creatinine control less than 20 ml per minute, that you cannot use fondaparinux, then you have to use Clexane. Sorry, you have to use the other part of anticoagulant. And that's about it, I think. And then the communication with the cardiology. In some case, you got to call Rihobam and say, look, you got to fly, then whatever. So these are the obstacles, basically. I only agree. But what can you do medical-wise? That's the thing. Okay? And probably this patient will not be discharged early. We have to keep longer things in it. That's the borderline. I think I could. Thank you. I'll be there. Time's up, isn't it? Yeah, thank you. I'll pass the baton also.
Thank you very much, Dr. Azrin, for the enthusiastic and enlightening lecture on STEMI equivalent. Please give him another round of applause. Thank you. At least from that lecture, we now have more than one diagnosis on our referral letter besides ACS. So the heart is an extraordinary organ. It is known to behave erratically, and the ECG may reflect something that we thought we know, but we actually don't. So our next speaker, Dr. Mansoor Yahya, will give a lecture on STEMI mimics. Please welcome.
Okay, Assalamualaikum warahmatullahi wabarakatuh. Thank you to organizing committee for inviting me for this interesting session, inshallah. Today, they give me the topic ECG on the ST elevation MI mimics. Okay, you can see that on the first and second lecture, she already have some form of the explanation, example of the case. Like ECG lights means the ST elevation to the infarction. Okay, but I will go further how to differentiate with sometimes the not typical ECG, but may represent the infarction, or maybe you thought this might be the infarction, but it's not. Okay. First of all, we have to go back to the very basic principle how to diagnose ST elevation to the infarction. So the ST elevation to the infarction is myocardial injury until proven otherwise. So it's 1 millimeter in 2 continuous leads of left bundle or left bundle branch block configuration meeting scapular criteria. Okay, or when ST elevation is when ST elevation is unlikely based on symptoms and demographics. So consider other etiologies of ST elevation. So read the serial ECG and then to look for evolution of ST elevation like the infarction pattern. Only 72% of patients with STEMI receive diagnosis in the first 1.5 hours. So this
mnemonic, mnemonic for this one. From the mnemonic elevation, this some to help remember which the ECG that we can mix the STEMI. First, this electrolytes. It's a hyperkalemia, which Azrin mentioned just now. So that the first lecture also mentioned some form of this electrolyte, mainly hyperkalemia. The second is a left bundle branch block. Okay, like the new left bundle branch block is likely to be acute ST elevation MI. Or in the presence of left bundle branch block, how to diagnose ST elevation myocardial infarction. Okay, the next one, early polarization. Dr. Ghazali mentioned a lot about early repolarization, but maybe repetition here. Okay, then in the presence of left ventricular hypertrophy. Okay, left ventricular hypertrophy. Next is aneurysm, especially the ventricular aneurysm. Okay, then the use for Thailand, because the Brugada is from Thailand, Brugada syndrome. Okay, then the inflammation, pericarditis, Osborne J. wave. Okay, in hypotonia. Then also the non-ischemic vasospasm. Okay, that some we mentioned in the first and second lecture just now. First one, hypokalemia. The hypokalemia is a peak T wave. Peak T wave without any concave down or tombstone ST elevation. Okay, I will show the example after this. The T wave of hypokalemia should be tall, symmetrical, pointed, and narrow. Okay, untreated hypokalemia can progress further to sinoventricular rhythm or sine wave. Okay, this what we can see the classical ECG changes according to the level of hyperkalemia. 6.5, 7, you can see the QS, the more bizarre shape. Okay, then when the 9, so it's sine wave. Okay, this ECG for hyperkalemia with big T wave and small P wave. You see the very tall T and then you can see the very tall narrow T, and then you see the T wave also is small. Okay, that is important. The history is very important. History, the scenario, the risk factors of the patient. Example, the patient have end-stage renal failure, cardiac casualty, maybe just come with shortness of breath. Example, so underlying diabetic, but after taking durian something. Example, okay. This is someone. Okay, then you see this is not classical chest pain. When you got the chest pains, and you have to more open-minded, right? Is it possible myocardial infarction or not? Okay, this is classical T, tented peak T wave with a small P wave in hypokalemia. This, you can see the widened QRS complex and tall broad T wave. This when the hypokalemia is more severe, okay, more severe. Then this one more confusing. You see, you like, is it Brugada, something like that? When you see that, then is it ST elevation, like the infarction? Then you have to look at the scenario, okay. Okay, this ECG shows sine wave pattern. You see here. I remember when I was very junior specialist many years ago, when I'm on call in the HRPZ. Okay, one patient is ST renal failure on hemodialysis. Okay, but he take a lot of rambutan just before that. So he come with the heart rate is about 30 plus. then this ECG, the use potassium unmeasurable. Just imagine, that time is dialysis is not as easier available as nowadays. I give 3 doses of cocktail regime. And then after that, only become 8 potassium. After 3 doses of, I can straight away. I don't think we will do that now. 3 doses straight away. Sometimes patient can severe hypokalemia also can have heart block also. That they can have block. Then after that, patient push for hemodialysis. Okay. Okay, for the next one is left bundle branch block. Left bundle block as well as any left bundle branch block configuration like RB based pacing can result the ST segment elevation, but usually less than 5 millimeter. We use the Sgabosa criteria to determine if there is concurrent myocardial infarction. Okay. In addition, we named for the Cabrera sign, Chapman signs. Actually, I'm also not that familiar, we have to study together. Okay, study together because it's not commonly used. For Sgabosa, it's more commonly used. And patient suspected. So through both, which are specific but poorly sensitive. Okay. Right bundle branch block does not typically give ST elevation. Therefore, in case of right bundle branch block, usually is standing rules to apply. Okay. This example how we look at the RSR and QRS in the right bundle branch block in the left bundle branch block. For left bundle branch block, you can see here this is the example case of left bundle branch block. Okay, there's the shape like that. This okay. What is simple thing to look for left bundle branch block? What we call is William. Okay, William. So in the here you like W at the end. At the end is sorry. Okay, then at the end we like N. So it's left bundle branch block. What we commonly use for. Okay. So Sgabosa criteria, the original criteria is if more than 3.98% probability of ST elevation myocardial infarction. ST elevation more than 1 millimeter in a lip with upward QRS concordant, this is 5 point. Okay, if ST depression, this second criteria, ST depression more than 1 millimeter, the V1, V2, V3, so we got 3 point. Okay, ST elevation more than 5 millimeter in lip with downward QRS complex discordant is 2 point. Okay, this is the point for Sgabosa. Okay, maybe we take notes because sometimes maybe this one we keep in our handphone, whatever the criteria, because sometimes you cannot remember straight away, right? Not tip of your finger, right? So that when you got problem, you refer back what's the criteria, so that this will help us to differentiate or diagnose correctly. With the Smith modification, they modified the Sgabosa third rule, this one. They changed the third rule of original Sgabosa to be ST depression or elevation discordant with QRS complex and with a magnitude of at least 25% of the QRS. This will increase the sensitivity from 52% to 91% at the expense of reduced specificity from 98% to 90%. So we make the diagnosis for STEMI more accurate. Okay, this example, the ECG, This all, he got all, fulfill all these three criteria. Okay, you got the ST segment elevation at least 1 millimeter in the concordant with the QRS complex in lead 2, you see, ST elevation here, okay. More than 1 millimeter. ST segment depression at least 1 millimeter in V2. Okay, ST depression more than at least 1 millimeter, V2, V3, and ST segment elevation at least 5 millimeter. That's discordant with the QRS complex lead to AVF. You see, it's more than 5 millimeter. Okay. So the next one is early repolarization. This is a normal variant often seen in the young athletes. I think the Dr. Razali mentioned is quite detailed on this early repolarization. Okay, synonymous with J point elevation, though not to be confused with the J wave. There is an elevation of the point where the QRS usually meets the piezoelectric line. Some studies suggest an increased risk of VF in this patient, though the lifetime risk remains unclear. The elevation in this case should be concave and greater in precordial leads. Okay, you see here, there is in the benign early deposition with generalized concave ST elevation in precordial V2 to V6 and limb slits. Concave ST elevation, okay, the V2 until V6, okay, then also in the limb slit, 2, 3 AVF. Sometimes, usually the patient really is symptomatic. You come from other thing, you found this one, then give thrombolytic. Really bad. It's early reproduction. And then you see the J point notching. This evidence in the inferior leads. J point notching. This is J point notching. You can see here the inferior leads. And then the ST elevation with a T ratio. With T ratio less than 0.25, you see here. Okay, ST elevation, but the compared to the T wave is less than 0.25. Another next one is left ventricular hypertrophy. Ventricular hypertrophy. And LVH typically with strain pattern, left ventricular strain pattern. The ST elevation should be in the V1 to V3 only, concave shape, discordant with deep S wave and not more than 2 millimeter elevation. Okay, you show the example. Okay, this example, the R in the V5, okay, R is in V5. This is tall R, tall R plus deep S in the V1 must be less than 41 millimeter, which is more than 35 millimeter. The sum is in this case is 41 millimeter. So it's more than 35 millimeter and represent left ventricular hypertrophy. This according to Sokolov Young criteria. Okay. These are the most commonly used. Then if D, a tall R V5 plus D S V6. Tall R in V5 or V6 with DS in the V1 more than 35 millimeter. The other criteria can be used as corner criteria, R in the AVL and S in the V3 more than 25 millimeter in men, but in women there's more than 20 millimeter. Okay. Other voltage based criteria, lead 1 R wave more than 40 millimeter, AVR S wave more than 50 millimeter, AVL R wave more than 12 millimeter, AVL, and so on. So this is another voltage criteria. Then the V4 to V6 critical leads may show ST depression and T wave inversion known as the left closing pattern. Okay, this the Romfield criteria diagnostic more than 5 point and probable is more than 4 point. This voltage criteria. Okay, this is okay. Quite a lot then. Okay. Okay, this some examples in mind. Okay, the next one, the aneurysm. Okay, left ventricular aneurysm. Usually after myocardial infarction, the wall of ventricle can become aneurysmal. This manifests as persistent ST elevation in territory of old infarct. Okay, so that when the patient, you see this, especially have recent myocardial infarction, especially the anterior myocardial infarction, you can see there's some persistent ST elevation. This is the sometimes more difficult when patient also have the chest pain when they presented to casualty example. Then you say, is it significant? Sometimes this especially is old infarct with the left ventricular aneurysm, maybe he has concomitant unstable angina. Again, so that not that straightforward. Okay. Then the Q wave should be present in the midst with persistent ST elevation. Okay, echo is important, required to find a confirmation. I think most the big hospital, A&E have the ultrasound machine, example. Then maybe there's an echo there can help for this diagnosis. Then another condition is Takasubo cardiomyopathy. This is a broken heart syndrome, usually related with stress cardiomyopathy. You can have a similar problem. Well, you see here this left ventricle. Okay, the thin wall within short axis view. You can see for long axis view, this wall is already thin out. This is infarcted. If very thin and bright, usually already have the fibrosis there, scarring there. Okay, this aortic aneurysm, the left ventricular aneurysm following myocardial infarction. Okay, this is the ECG. You see the left ventricular aneurysm, the ST elevation with the anterior leads, you see here. Okay, V3, V4. Okay, we got like Q wave will be by ST elevation here. Okay, sometimes if you reflect that, maybe you saw many patients thrombolized with this ECG. So it's not right. Sometimes if thrombolized, patient may have the complication like intracranial bleed, a bleeding problem with unnecessary treatment. Okay. This persistent, the ECG persistent characteristic ST elevation after myocardial infarction with non-specific ST segment changes, Q or QS wave, T wave small relative to QRS, no reciprocal changes. Okay. Takotsubo cardiomyopathy. Takotsubo cardiomyopathy or transient apical ballooning syndrome or stress-induced cardiomyopathy. This is a bulging out of left apex, left ventricular apex with preserved function of the base. Looks like an octopus spot or takotsubo in Japanese. And recent recognition of additional subtype with reverse takotsubo vessel ballooning, mid-ventricular type or localized type. 85% of the cases caused by stressful event before symptom.
death of loved one, fear, argument, asthma, surgery, stroke. And sometimes you got crisis at work or at home. Sometimes it's like that, heart failure, example, you can have that, you know. So the proposed mechanism, including the vasospasm, microvascular dysfunction, and abnormal lifestyle respond to catecholamine surge. This as high as 28% in ICU patient due to severe physical stress. Okay, you might have this. Okay. The clinical syndrome dislikes the acute coronary syndrome, some chest pain, dyspnea, cardiac shock, sudden congestive heart failure, can conflict arrhythmia, VT, PEA. Okay, you can see the left ventricular dilatation that occurs in Takotsubo cardiomyopathy, you compare to the normal heart. So much like the infarct, post-infarct left ventricular aneurysm. Okay. The next one is Thailand, Brugada syndrome. I remember last time Dr. Razali so excited when I'm very junior at that time. I just become specialist about Brugada syndrome. He trace a lot of the family members have this cardiac members of patient have the cardiac arrhythmias. Okay, VT, VF. Okay, then it is the family members who need the pacemaker, not pacemaker, IECG. Okay, this cardiac sodium channel mutation usually is SCN5A, which was first described in Thailand in 1992. Is may be responsible to 4 to 5% of sudden cardiac death. Okay. Got these three described ECG types. Type 1 and 2 is more common, give ST elevation. Type 3 has saddleback appearance without ST elevation. This can be pharmacological unveiled, example, arrhythmics such as sodium channel blockers. Okay, it's treated by illness or fever. Okay, when the patient got fever, you can see the features more prominent, or be intermittent, which commonly seen as an incomplete right bundle branch block. Okay, this is a rare syndrome, inherited arrhythmic disorder causing an increased risk of syncope and sudden death due to ventricular fibrillation, considered as cause of syncope in patient with family history of sudden death. That is important to if patient got ECG like some form of Brugada syndrome, you ask any family history of sudden death. Okay. 80% of Brugada syndrome diagnosed only after a cardiac arrest, survive cardiac arrest. Then you see that then need to investigate the family members. This is autosomal dominant, so the channelopathy with increased risk of sudden cardiac death, about 10% per year. It's more common in men. It's 9 times, particularly in Southeast Asia males in our area. Okay, ECG shows incomplete right bundle branch block with the SC elevation in V1 to V3. In uncomplicated right bundle branch block, usually there is no ST changes to slight ST depression. Presenting symptom is chest pain rather than syncope, considered strongly staining. Okay, that's the okay. Usually, this patient is asymptomatic, but patient can have the ventricular fibrillation cardiac arrest of sudden death. So, diagnostic ECG finding transient and variable, with only 1/3 of serial ECGs diagnostic in confirmed spontaneous cough type Brugada syndrome patient. Okay. This you see the type 1. Type 1 here
The ST elevation segment more than 2 millimeter with descents with upward convexity to T wave inversion. You see, yeah, ST elevation down more than 2 millimeter, and then with the descent upward is to T wave inversion. For type 2, the elevated ST segment more than 1 millimeter descend toward this line. Okay. Then raise again, settle back to upright T wave. Okay, the type 3 is elevated S2 segment less than 1 millimeter. With this descend toward this line, then raise again to upward T wave. Okay, this is a difference. So for V1 and V2 lead placement in the second and third intercostal space, rather than usual for intercostal space, it can increase chance to see the type 1 pattern. So you just suspicious you make the ECG when the V1, V2 and the second and third intercostal space so that you can see more. The next one is the inflammation, is pericarditis. Okay, diffuse ST elevation. In acute presentation, there may be the PR elevation and the ST depression in AVR only, but this is poorly sensitive. Okay? PR depression classically thought as ECG sign of pericarditis, but only occur in the viral pericarditis. Consider the diagnosis of STEMI in favor of pericarditis when there is ST depression anywhere, except for V1 AVR. So ST elevation height is in the 3 more than 2. Okay, there is a convex horizontal ST elevation of 4D or there are new Q waves. Okay, this is how to look for possible STEMI rather than the pericarditis. If predominantly inferior elevation, depression in AVL is very sensitive for STEMI. Okay. So classical teaching is the mass reflex from STEMI with the casuistic not specific enough to do that. Classically, pericarditis or diffuse ST elevation, but it can be very localized ST elevation. And pericarditis should never produce ST depression. Okay, suggestive of a frequency changes is AV1 and AVR. Classically, we got the concave outward ST elevation. However, STEMI may have concave outward ST elevation morphology also. So rather, it is ST convex outward or horizontal favors STEMI. Classically, the pericarditis got PR depression in the viral pericarditis. Or it can have the PR elevation in AVR. So less reliable in post-MI patient and those with baseline ECG abnormality. PR depression often early and transient in pericarditis. In STEMI, PR depression associated with the atrial injury, though usually not as marked as a viral pericarditis. PR elevation in AVR may be present in STEMI. So, and this frequency constrictive in constrictive pericarditis. Other finding lead to 3 ST elevation in the 2 more than 3 favor pericarditis. If the 3 more than 2 in favor of STEMI, ST depression not in the AVR or V1, so suggest as STEMI. In early revolution, the confounding interpretation check STT ratio. Okay, the independent inferior ST elevation, ST depression in AVR is sensitive for STEMI. Spodic sign, probably more than 80% downsloping TP segment of the best seen in lead 2 and lateral precordial lead. T wave inversion don't invert in pericarditis anti-ST elevation resolve. In T wave inversion and ST elevation stimulus is present more likely ACS. Okay, stage progression of the pericarditis. Stage 1, global concave of ST elevation in all leads. Excuse me. Okay, 2T depression. Okay. Between the end of the P wave and the beginning of QS complex. Stage 2, pseudo normalization. Is this segment return to baseline last T wave, PR depression. Stage 3, T wave flattening progression to inversion. Stage 4 is return to baseline. Okay, this is what we call the AD more than 0.25. Okay, these are sporadic signs. You see ST segment of PR depression. Okay, the stage of pericarditis I mentioned just now, the PR depression. Okay. STEMI versus pericarditis, you see the pain. Usually the STEMI persistent, but the pericarditis varies with motion. Fever usually present in the pericarditis. ECG changes more diffuse in the pericarditis. There is no reciprocal changes. There is no Q wave in the pericarditis. The tauedema is quite common in STEMI rather than the pericarditis. The wall motion abnormality is normal in the pericarditis. That is one. Okay, it's almost finishing. This Osborne wave. Okay, the J point. Okay, ECG. Okay, usually the sorry. In hypothermia, you got one topic in this area. You got bradycardia, including AV block, AF is common, moderate to severe hypothermia. Okay, they got risk for VF. There's Osborne J wave. Okay, muscle tremor, artifact, T wave inversion, PR, QS, QT prolongation, ST segment elevation, depression, on heart block and PVCs. This Osborne J wave. Okay, I think this atrial fibrillation in hypothermia. Okay, another one is the last slide, the non-ischemic vasospasm. This very difficult to decide because the symptom can be do angiogram. You say it's normal angiogram maybe. Then like the myocardial infarction. Okay, so thank you.
Thank you, Dr. Mansour, for the very informative lectures on STEMI mimics. Okay, before we move on further, I just still want to remind our participants that on your goodie bags, there are groups of your teams for your exercise session for this evening. And I'd like to remind all participants that